Good day. Welcome to another topic in General Pathology Laboratory. So today we will be discussing breast pathology. So in here you will have benign breast disorders as well as malignant breast disorders. So let's begin. The most commonly encountered benign tumor of the female breast is what we call as fibroadenoma. It is usually seen in adolescents and young women. From the name itself, you have fibro and adeno. So this is a benign biphasic tumor comprised of glandular epithelium and your interlobular stroma of the terminal ductal lobular unit. Since this is benign, it is usually painless, but it's firm, mobile also. It is a slow-growing mass. It is usually solitary, but some women present with multiple fibroadenomas as well as bilaterally. Sizes of this benign tumor would range from small to large sizes, but usually they are less than 3 centimeters in diameter. This is the picture of fibroadenoma. You take note of the edges of this tumor. You see that it is well circumscribed. It has lobulated contours. The color is white-gray or yellow-white, and you don't appreciate necrotic changes. There are slit-like spaces that you could also see. Under the microscope, fibroadenoma is also true to itself. You see the fibrostroma component, which actually compresses the ducts. The ducts are lined by your benign-looking cuboidal epithelium. So these are the ducts. As you can see, they are somewhat compressed, and so you see different shapes of these ducts. And the stroma, as you can see, are hypercellular. On closer view, you can appreciate here the cellular stroma. Again, what type of stroma is affected in fibroadenoma? It's your interlobular stroma. And you look at the lining epithelium of the ducts. The ducts are lined by benign appearing cuboidal epithelium. Next is fibrocystic changes of the breast. This is a benign entity as well, but it is commonly seen in women aging 25 to 45 years old. There is reduced incidence in postmenopausal women due to reduced serum estrogens, but is maintained by estrogen replacement therapy or estrones in adipose tissue in obese women. Fibrocystic changes of the breast is also common in women with polycystic ovaries. So from the definition a while ago, fibrocystic changes of the breast is associated with hormonal imbalance. So there is somewhat an increased estrogen to progesterone ratio. Decreased risk with oral contraceptives perhaps is due to balanced supply of estrogens and progesterone. This is rather benign, as I have mentioned a while ago. It's not neoplastic, but in some cases you may confuse it with malignancy. Usually, fibrocystic changes of the breast affects both breasts, so it's bilateral. although one of the breasts may be affected more than the other. Grossly, it is also true to its name from the word fibro and cystic. So you see the fibrous components as seen in the picture and also cystic areas. Cysts can be seen as clear or blue dome cysts, and they usually measure 1 to 2 millimeters, but sometimes they can reach up to 2 centimeters. Under the microscope, you can still appreciate fibrosis of the stroma as well as dilated ducts, which represents your cysts. On closer view, the ductal epithelium is still lined by benign-looking uniform cuboidal cells. Next is sclerosing adenosis. Sclerosing adenosis comes to attention because it appears as a palpable mass, dense on radiologic studies, or it may present with calcifications. Sclerosing adenosis will present with increased number of acini, and these acini are rather compressed and look distorted. They are compressed and distorted because of the stromal fibrosis, and so they appear as solid cords or double strands of cells lying within dense stroma. And this appearance under the microscope at times closely mimics invasive carcinoma. So grossly, sclerosing adenosis appears multinodular, and you cannot cut it directly or with ease. It has increased resistance to cuts, but when you cut it, it's somewhat gritty but no chalky yellow-white foci or streaks. Under the microscope, sclerosing adenosis looks like this. So it's still a benign entity. It's a well-defined mass, but with increased number of acini. These acini are compressed because of stromal fibrosis. And this compression will lead to a difficult diagnosis because it may look like a malignancy. Showing here the stromal fibrosis as pointed by the green arrow. Here is a picture of the distorted acini due to stromal fibrosis. And so some acini, as you can see here, are seen in cords. Next is breast carcinoma. Breast cancers or breast carcinoma are most common in women, and it's a second only to lung cancer as cause of cancer deaths. It's the most common non-skin malignancy in women. Almost all breast malignancies are adenocarcinomas because the breast tissue in itself is a glandular tissue. Carcinoma of the breast per se is rare in women younger than 25, but incidence increases rapidly after 30. There are different types of breast cancers according to whether they are ER positive or ER negative, NR2 positive or negative. So ER positive cancers continue to increase with age, while ER negative cancers and HER2 positive cancers remain relatively constant. Here is the gross picture of a breast cancer. As you can see, the borders of the tumor is ill-defined. So not like your benign tumors, which is well-defined. Under the microscope, there is loss of normal breast architecture. Cords and nests of atypical cells are rather seen haphazardly infiltrating the fibrostroma. When you look at this, there are atypical cells seen in nests infiltrating the fibrostroma. These atypical cells have increased nuclear cytoplasmic ratio, prominent nucleoli, and increased pleomorphism. Next malignancy is Paget disease of the breast. Yes, this is a breast malignancy. It is rather rare, about 1 to 4% of cases, and it presents usually as a unilateral erythematous eruption with scaly crust. Most common presentation is pruritus, and so the lesion may be mistaken for an eczema. What we will see here are Paget cells, which are the malignant cells, and they usually extend from a ductal carcinoma in situ within the ductal system via the lactiferous sinuses into the nipple skin without crossing the basement membrane. So tumor cells disrupt the normal epithelial barrier, allowing extracellular fluid to seep out onto the nipple surface. Paget cells are readily detected through biopsy of the nipple area or cytologic preparations of the exudate. So grossly, you will see the breast tissue as erythematous in the nipple area, sometimes affecting the areolar area as well. So it's scaly and crusty in appearance, and the person experiences pruritic changes in that area of the breast. Under the microscope, this is what you see. So Paget cells are rather somewhat large cells. You see more on the basal layer of the epithelium. And sometimes you will appreciate dermal invasion of these Paget cells. So these are the Paget cells that has invaded into the dermal layer. So Paget disease of the breast presents with malignant cells we call as Paget cells. These cells are large cells infiltrating the epidermis. It somewhat represents, again, as I've mentioned earlier, an intraepithelial extension of an underlying ductal carcinoma in situ or an invasive ductal carcinoma. So these are the large cells which we call as your Paget cells. They are the atypical cells for your Paget disease of the breast. Next is infiltrating lobular carcinoma. In contrast to other breast carcinomas, especially to invasive ductal carcinoma, infiltrating lobular carcinoma is an invasive mammary carcinoma that lacks cellular adhesion proteins. Tumor is composed of non-cohesive cells that are individually dispersed or arranged in a single file pattern. And there is also minimal desmoplastic response. Here you will see these cohesive infiltrating tumor cells, and you can actually appreciate a pattern. Pattern as mentioned, you see these atypical cells forming lines, and this is what we call as the Indian file pattern. Next is medullary carcinoma. These typically present as a soft, palpable circumscribed mass which may appear benign. Tumors with dense lymphocytic infiltrates are more likely to respond to chemotherapy. So one of the prognostic factors with regards to response to chemotherapy is the presence of lymphocytes in the tumor. Grossly, you may appreciate a well-circumscribed area, but there are areas of necrosis and cystic degeneration. Under the microscope, you may appreciate a well-defined mass with pushing border of solid sheets of atypical cells. Closely, we see the solid sheets of atypical cells admixed with lymphocytes. Again, the presence of lymphocytes are important in prognostication. Atypical cells also show pleomorphism and prominent nucleoli. That's all for the breast pathology. Please take note of everything we have discussed and study also Robin's book and Robin's Atlas. Thank you.